So I am going to speak to you about global issues and political problems. I have, first of all, to make my disclosure. As a statistician and a methodologist, I have belonged to the French National Committee for Drug Reimbursement, and now I am a consultant in methodology and statistics for many pharmaceutical firms, nearly always outside the field of child and adolescent psychiatry and even psychiatry. Now, this is my disclosure, but in fact my main conflict of interest with my topic, you have it also. I love my job. And I want always that my patient have the best care. And to have the best care, it requires resource, money. And so I am never happy about the level of resource that the French government dedicates to child and adolescent psychiatry. And this is inevitable. And so the main question is not, why isn't it a political priority? But the first question is, should it be a political priority? Because we are basically biased in our way to determine if it should be a priority or not. To determine if it should be a priority, you should evaluate two things. First, the burden of disease. Second, the level of country resource dedicated to child and adolescent psychiatry. Concerning the burden of disease, for long we had no data. And fortunately, recently, in 2010, WHO produced a very interesting document with methodological limitation, obviously, but this is a very good basis of discussion. WHO has classified for all age the level of burden of disease according to medical specialty. And you can find here the results for the whole planet, and you can see that mental and behavioral disorder are in the third position, but immediately you see the bias that can exist. When you see the second one, it is unintentional injuries, and you know that many child and adolescent psychiatric disorder can lead to unintentional injuries, like ADHD, for instance. Another methodological limitation is that these DALYs, disability-adjusted life years, are estimated only on the short term because we have no data, very few data, on the long-term effect of mental disorder in child and adolescent, and you know that there is a long-term effect. In addition, these DALYs do not incorporate the effect of the child disorder on the parents. There is an impact on the family also. So, nevertheless, this is the third rank position on the whole planet, and in developed countries and in America, this is by far the first rank. So, indeed, we have now data, strong data, which say that child and adolescent psychiatry lead to an important burden of disease. Now, concerning resource, unfortunately, we have not this global picture. This has been acknowledged by WHO in 2006. Why? Perhaps, and obviously, there are technical difficulties to determine the level of resource dedicated to child and adolescent mental health, because it can come for health, for disability, for handicap, etc., for school also. This is the first possibility. The second possibility is that because people do not consider basically that it is the main problem, they do not do research in that. A third point is that perhaps we do not do enough efforts to do health economic studies in our field, and we are wrong with that. We should do that. Nevertheless, we have some ideas about the level of country resource dedicated to child and adolescent psychiatry because we have data for adult psychiatry. And these data have been published in a series of papers in The Lancet in 2007, and the answer is yes, especially in low and middle income countries. The levels of resource dedicated to mental health is unfair as regards the level of resource dedicated to other medical disciplines, and when you compare it, all things being equal in terms of burden of disease. And so we will make the hypothesis that it is the same for child and adolescent psychiatry. I do believe that, but unfortunately, I cannot say that that there are evidence about this question. So, yes, child and adolescent mental health should be a priority. And it is not a priority, then the question is why? Why isn't it a priority? At this beginning of this presentation, I will propose you 3 arguments to explain that. The first one is the curse of care, the second, the ambivalence towards kids and adolescents, and the third one, the question of anti-psychiatry. When I speak about care here, I speak about the concept developed by Carol Gilligan, just to be sure that we all speak about the same thing. This American philosopher suggests that in many countries, in many cultures, women are dedicated to protect interpersonal, interrelationships, and to provide care, especially to youth and old people. And because many of these countries and cultures are of a patriarchal nature, what do women is considered as valueless? And by the way, care is considered as valueless. This is not true in all cultures, and this has not been true in all periods of time. For instance, in Middle Age, in Europe, it was considered that singers and professors shouldn't be paid for their job because it was a gift of God to be able to sing and to be able to have knowledge. And today, among the persons who earn the most important amount of money, you have singers. And today, these things have changed, and sociologists say that it is people who provide care or prostitutes who shouldn't earn any money with their job. Perhaps in 500 years, things will have changed and we will earn a lot of money. So, nevertheless, there is a question of curse of care. Why, especially in child and adolescent mental health? Because indeed, as opposed to surgery, we have to use language, you have to use care. For instance, in psychological treatment, there is empathy, and empathy is a part of care. Care is an important part of our treatment, and because people consider that care is valueless, so psychological treatment and child and adolescent psychiatry is somewhat valueless also. In other cultures, people consider that it is not to physicians to decide and to treat child and adolescent with this problem. It is to families and religion. I have experienced that a couple of years ago when I went in the Gaza trip in a mission for MSF. The Hamas had decided that the psychological treatment proposed to the children shouldn't be given anymore because it was considered something like an American culture. And we had the opportunity to discuss with the Vice Minister of Health of the Hamas, and he explained us that, well, this is not your job, this is not a medical problem. Islam and the Muslim family is enough to take into consideration this problem. And we have to discuss about that. And the good news is that we succeed in having a very productive discussion with this person. The last point is that, you know, we are fascinated by high-tech devices. And even in medicine, people are fascinated by MRI, etc., etc. And at the moment, in our job, we can do that, but this is not our the core of our job. And so often people consider that we do something different. The second point is about the ambivalence toward kids and adolescents. Everybody considers that everybody loves children, loves kids, because this is natural. And because everybody loves children, societies should invest a lot in children, because it is the future. This seems obvious. But in fact, you know that indeed everybody loves kids, but Nearly everybody hates kids from time to time also. You know that many famous authors like Winnicott have written beautiful pages about that. The mother hates her kid because she becomes a slave, because the kid refuses good food, and this is an humiliation, etc., etc. But this is repressed, you know, and this is very difficult to struggle against things who are depressed, especially in the mind of politicians. Second point, there are children and there are adolescents. And you know that there is a tension in our society between adults and adolescents. We consider that they are violent, even if it is not true. There are data about the level of violence across age. And this is not during adolescence that it is the highest important. You know that it is at 3 years old that human beings are the most violent. This is reality. No, perhaps we don't like adolescents because they are much more sexually appealing than we are, and we are jealous about that. The last point is that, you know, our patients often do not raise empathic reaction. When you have a children with leukemia, people consider this is completely unfair. This is fate. This is unacceptable. When a kid has a conduct disorder, this is because of him, because of his parents. And so you have two penalties, one from the disorder, the second from the stigma by the society. Concerning the anti-psychiatric movement, this is an old story, you know that. People consider that child and adolescent is only a fantasy. These disorders do not exist, at least only in the mind of child and adolescent psychiatrists. Why? Because children are pure. They cannot suffer from anything except it from their body. Because they have not to deal with the burden of existence. Everything is fine for children. Of course, this is not true. We know that. This is not true, but this is the fantasy of many people. So, what have we done to struggle against that? We have used a very efficient weapon, which is science. And it was good. Against the curse of care, we have shown that psychological treatment are not just care, they are evidence-based. There are many randomized controlled trials which show that these treatments are effective and efficient. Even psychodynamic treatment, who are considered as some kind of romantic entertainment by many people on the planet, but they are shown as evidence-based with randomized controlled trials, and they are highly technical. It requires many, many years of training to become a good psychotherapist. First point. Second point about ambivalence toward kids and adolescents. Epidemiologists have put number where people were putting emotions. Epidemiology has shown that when you look at SMR, standardized mortality ratio, the outcome of anorexia nervosa that require hospitalization is the same like Hodgkin disease, which is a leukemia. So this is not fair to consider that psychiatric disorders are just nothing, they are just like leukemia. And health economy has shown also that the burden of disease indeed is important. Concerning the anti-psychiatric movement, neuroscience were very useful because now we can show to people that a psychiatric disorder has put a print on the brain. You can see on brain imaging a mental disorder. So this is not a fantasy if you can see it. On my point of view, this is a major positive thing that brain imaging brings to child and adolescent psychiatry. Okay, so we did that and we were right, and it was not a complete success. We are still not heard. People are suspicious about us. And I think that for a couple of years, we are now, many of us are considered as cold-blooded physicians pretentious and dangerous. This is my feeling, and my opinion is that, in part, we are responsible of that. Why? Because we are cold-blooded. In a way, yes, we have been so interested in the brain that from time to time we have forgotten that there was a person above or behind the brain, and that our job is primary to deal with the person, and the brain is just after, it is just a surrogate thing. We are pretentious, yes, yes, yes. Many times when I heard neuroscientific colleagues dressed in their white coat saying that science has found the basis of consciousness, this looks like a lay and high-tech priest, but nothing more. And many people believe that. And many people consider that, in a way, this is dangerous. And this is all the more dangerous that people think that we basically will be happy only when all kids will be on medication. And this is not completely crazy. Look at the epidemiological figure we propose to people and to politicians in very good journal, with very good colleagues, with very good studies. We can write in conclusion that lifetime prevalence of mental disorder in adolescents is about 50%. And we believe that, but nobody else believes that. When you go to a politician and you say, well, half of adolescents have a psychiatric disorder, they say, wow, these guys are crazy. And even if they are right, we can do nothing for half of the adolescents. This is not intractable. People are scared by us. Psychiatrists don't listen to us. People don't believe them, this is what I was going to say, and people are going to look outside psychiatry. And you know that more and more the notion of mental health becomes something more relevant in people's minds than psychiatry. And this is not only a question of political correctness. You know also that in many countries money goes to disability or to mental handicap more than psychiatry. So, as I said, we did well with science, but obviously we have to consider things a little bit differently. Of course, we have to continue to improve clinical practice, because if we succeed in treating our patient, people will acknowledge that we are good with our job, and we will become credible. We have to continue to do science. Neuroscience, evidence-based medicine, epidemiology, of course, but we have to do science which is closer to patients and to patient experience and need. That is social and human science. I will just give you one example. Do the following experiment. Ask to some residents, young residents, well, imagine I am a patient, you propose to me an SSRI, okay. But I ask to you, well, you are giving me this pill, okay, but what will be the effect of the pill on me? How will I change after the pill? I have done this experiment a couple of times. You have a silence first. Well, if I give an antidepressant, the patient will be less depressed. Yes, okay, but this is not how he feels. Okay, he will be less sad, less anxious. He will sleep better. Okay, but if you ask to patients, if you do a qualitative research using intersubjective phenomenological analysis, you will have some very different results that I summarized by just a sentence given by a patient. I could hear the anxiety yelling somewhere inside me, but it was muffled, as if someone had put up soundproof glass. You know, this is very different with saying that antidepressive drug just decrease the level of symptoms. You know, and we have very, very few studies of this kind at the moment available. And this is a pity, because most of our family or our patients are asking us this question. So, okay, we have to continue to do science and perhaps to open our research method to qualitative design and social and human science. Okay, but this will not be enough. I think that at this moment, we are in a conceptual impasse. We cannot advance because of that. And this conceptual impasse comes from a postulate that we have done, and this postulate is not correct. This postulate is that a psychiatric patient is, by definition, a person with a psychiatric disease, and because psychiatric disease is no more in fashion, this is the same as a person with a mental health disorder. Most of our colleagues consider that these three equalities are true, and this is not true. This is not true, and I am going to show you that basically these three things are basically different, and because of this misconception, we have a conceptual blur which makes that all what we say, especially in terms of descriptive epidemiology, is misunderstood by people who are listening to us. So first, I will come to the question of what is a psychiatric patient. And you can also ask the question to residents, you will have surprise. My favorite definition of a psychiatric patient comes from a French philosopher, Georges Canguilhem. He said, the doctor is called by the patient. And I thank you here, Gordon Harper, my dear colleague, who helped me to write this slide in good English, and I am sorry for my speaking English, which is obviously not that good. Call means summon here. That is, what is the definition of a patient? It is a person who rings the bell of the physician. This is the definition of a patient. And so you could say that a psychiatric patient is a person who calls for some help because this person suffers in his mind or from his behavior. And of course you will tell me, but in psychiatry this is not the same because there is denying sometimes. Sometimes people do not realize that they have a problem. Okay. And in child and adolescent psychiatry this is even more tricky. I'm sure that this is the same for you than for me, but at least 50% of the time when I ask to my patient, why do you come to see me? I say, I don't know. I don't know. So, yes, it is more tricky, and you could consider, in a way, that the child and adolescent psychiatric patient is not a human being, it is a community. And I suggest, for instance, that you could define a child and adolescent psychiatric patient as a community that calls for help for some suffering in the mind or behavior, and which locates this suffering in youth. Okay, so we have a definition of a psychiatric patient. So now, what is the definition of a psychiatric disease? This is a very old question with hundreds of books, thousands of papers, and for a French-speaking person, it is a disaster because you have so many words. You have disease, illness, sickness. We have only one word, maladie. And this is at least a symptom of something which is difficult. You know, if it is different from a language to another language, it means that we are not clear with that. I have found a very good paper in medical humanities which says that in English, the disease is seen by the physician, the illness is experienced by the patient, and what the patient shows to society is sickness. This is what I understand from your language. Many authors have discussed also about the natural condition or not of psychiatric disease. Do they really exist, or are they only words? Are psychiatric disease, when we see psychiatric disease, do we carve the nature at its joints? Does it exist, joints, in the nature of psychiatric symptoms? This is an open question. And I like here the work of an American philosopher, Peter Zakar, who has shown that, in fact, psychiatric disease can have many facets. First, it can correspond to biological dysfunction, serotonin for depression, dopamine for schizophrenia. It can correspond to pattern of symptoms, like in the DSM. Categories used by health insurance, and this is very important. I am sure that the increasing prevalence in borderline this is a Freudian slip, in bipolar disorder, comes from the fact that it is much well reimbursed than other disorders, in particular personality disorders. Categories used by judge. If for certain categories you do a big mistake in not doing a certain exam, then you are likely not to give this diagnosis anymore. The media, you know that schizophrenia in the media has not at all the same meaning as for psychiatrists, and at least for sociologists. Sociologists who have a very different way to consider psychiatric disorder, psychiatric disease. Just for example, the proposal for depression of wariness of self, which is tricky for psychiatrists, but really interesting. So this is very, very open to discussion. My personal point of view is that what I call psychiatric disease is what we could imagine that ET, the extraterrestrial, could experience if his first apparition on the Earth was in a museum of modern arts of painting from the 20th century. ET would see paintings, and after a careful examination of these paintings, he would consider that some look like to some other. This is what we call the Cubist, the Impressionist, the Surrealist. And after, even inside the Surrealist, there are subclusters, sub-syndromes. Indeed, Dali is a Surrealist, and Picasso had a Surrealist period, and they are both Surrealists, but in a different manner. And the tricky thing is that if you look at Cubist painting, you can find painting close to some Surrealist painting because both have been painted by Picasso. This is some kind of transnosographic psychopathology. This is very complex, and you can say, well, this is too complex, I will only consider figurative and non-figurative paintings. This is in a way what do psychoanalysts. You can also use a microscope to see the quality of the painting. This is what do biological psychiatrists. But at the end, what is the reality of this cluster? What is the reality of our diagnosis? Perhaps, well, Picasso does exist, but there are many Picasso, many periods. Are they much more relevant than the movement, the style of painting? I don't know. Nevertheless, this is very academic. Just to be simple, you can consider that psychiatric disease are biological and syndromic construct, so that biological, the NIMH will be pleased, and syndromic, the DSM will be pleased, and so I will be restful. But this is not enough, and you know that. And this is also the case in medicine. Do you say that all common colds are disease? Even near osteoarthritis, you know, after 45 years old, nearly a majority of people have X-ray symptoms and clinical symptoms of knee osteoarthritis. Is it a disease? This is just life. If you consider that all biological and syndromic constructs are disease, then disease is just life, because we have disease permanently. You know that it is said that every minute we have one cell which becomes a cancer, and it is immediately killed by our lymphocytes. So we are disease. So this is not enough. And even in psychiatry, this is true. I have loved this paper written by Robert Spitzer that you all know, which is a very wise person who wrote a wonderful paper, Diagnosis and Need for Treatment are not the same. The wording, it was a discussion paper of another paper, so the wording is not necessarily the good one, but Spitzer says that, well, you have phenotypes, this is diagnosis, and you have psychiatry, well, people with psychiatric disease. This is not the same. This is not the same. And you will say, yes, of course, this is not the same because there is a level of functioning, there is impairment. To have a psychiatric disease, you need a syndrome and some alteration in functioning. Okay, but it has never worked. Epidemiologists have tried to operationalize the impact on functioning and it does not work. Why does it not work? Because this is dimensional, you know. And where is the threshold which determines that it is a disease or not a disease? This is not a necessary condition, you know. In some psychiatric disease, you have no alteration of impairment. In anorexia nervosa, you know that perfectly. But also in very early stage of autism or in schizophrenia, hopefully, between crises, you can have people without any symptoms while they have a psychiatric disease. This is neither a sufficient condition, even if it can be discussed. In the past, bereavement is something painful, with distress, with impairment potentially, and it was not considered as a psychiatric disease. And you know that it has changed recently in the DSM, but I know that this has been discussed in the United States, and I have read the work of Jerome Wakefield, very interesting about that, about the tension, should bereavement be considered as a psychiatric diagnosis or not. And what is curious is that this question is crucial, and there are so few research on it. Okay, at this stage, I have done a lot of critiques and I have to be constructive. And I want to propose you a way to define a psychiatric disease. Of course, a psychiatric disease is a biological or a syndromic construct, but it has also an impact on the experience that the patient has about life. I propose that a phenomenological perspective about mental disorder. By phenomenology, I mean phenomenology which comes from the German philosophy, from Husserl and Jasper, and I know that in the United States the word has got different meaning across decades during the 20th century. There has been a very beautiful paper written in philosophy, psychiatry and psychology by Mona Gupta about the evolution of the notion of phenomenology in the United States. Which is curious is that in the DSM it is mentioned that the DSM relies on phenomenology, but it is phenomenology considered as the observation of objective things, which is exactly the opposite of the definition, of the original definition of phenomenology, which is how people experience existence. So this is basically subjective, So, I propose that when a patient has a psychiatric disease, he or you, as an empathic physician, experience subjectively something which is very different, very unusual. The patient is helpless, desperate, anguished, lost in his mind. He is an intruder to himself. He is humiliated because of that. You know, this is a very severe narcissistic failure to be lost in his mind. This is a dramatic situation, you know. People say, help me, or just let me. I would like you help me, but I don't think this is possible because what I experience is completely unbelievable. There is a loss of control. There is no more possibility of adjustment. The patient feels that he cannot deal anymore with reality. And you, as physician, you cannot do anything just in changing the school, the parents, or in giving good words. This does not work. And because you have the feeling to be in a death end, something in the room appears which is the specter of death. There is no more solution. In fact, death could be the only solution. Something also which is very interesting is that because there is a rupture, because it is so different, it cannot be only a problem of mind. This is not scientific what I say, this is phenomenologic, that is our subjective experience of what happens. And in some culture, people say, well, this is a possession, the devil has entered the patient. But this is no more in fashion in our Occidental culture, and we say this is a problem of the body. The body has to be involved in the problem because it is so extraordinary. And which is amazing is that 1500 years ago, one of our first colleagues mentioned that those who think that mania is essentially a disease of the soul and secondarily of the body are misleading because no philosopher has ever cured that disease. You know, 1500 years ago, physicians already considered that some psychiatric phenomenon couldn't be only a problem of the mind. And this is still exactly what we experience. What we experience is that when we face a patient with a psychiatric disease, we are no more in front of a normal human being. We are in front of a distorted human being. This is exactly what tries to express Francis Bacon in his painting. Now, I come to mental health disorder. Is it different from psychiatric disease? Yes, indeed. Yes, indeed. Just look at the definition of WHO of mental health. It includes subjective well-being, perceived self-efficacy, autonomy, competence, intergenerational dependence, self-actualization, etc. Look at the second paragraph. From a cross-cultural perspective, it is nearly impossible to define mental health. However, very important, generally agreed that mental health is broader than a lack of mental disorder. This definition is completely crazy. Inside the definition, it is that there is no definition possible. So what is my interpretation of this definition? First, that mental health is everything which concerns a human being considered as a thinking subject. You know, subjective well-being, autonomy, self-actualization, this is nearly everything. Second point, mental health is not the business of psychiatrists. Many people feel a need to be autonomous from psychiatry. And this is exactly what is the claim in the definition of mental health by WHO. Is it so important? In the rest of health, you have tension between health and medicine. This is a very old question, but in mental health, the topic is particularly hot. Why? Because you know we have all experienced problems with our mind, and this is frequent, in fact. And for many people, for many people, there is always this question, well, these problems that I experience, are they just normal, or perhaps I am insane? This question it makes that we are human beings. And I don't know you, but when I came for the first time in a psychiatric hospital, I was a little bit scared not to have the possibility to go out anymore after. Because you have always this question, I am really sane or not? And the second point is that, as opposed to other physicians, psychiatrists can lock up people. Of course, we are very serious about that. But on a symbolic point of view, this is something very, very strong. A cancerologist cannot impose a treatment in most countries to a patient. A psychiatrist, in a way, can do that. This is a major difference. And this makes that there can be some element of violence in psychiatric diagnosis. Okay, so now I am going to come quietly to my conclusion. In your job, in our job, there are some people who come to call for help because of their mind or their behavior, and these people, by definition, we call them patients. Among these patients, some have nothing, and I am sure that in your consultation it happens that parents bring children and adolescents who have just nothing, and that's fine. That's fine. Some of our patients have psychiatric phenotypes, that is, syndromes. Okay? Okay, this can be problematic. We can propose solution. Okay, but they are not psychiatric patients with psychiatric disease because they have not this phenomenological rupture that you observe when you face a psychiatric disorder, a psychiatric disease. So you have three types of patients. When you face a patient with a psychiatric disease, society gives you a very particular legitimacy. Because you are a psychiatrist, you can say things about psychiatry. You can lock up people, you can propose drugs which are medication, and you have an authority to do that. When you consider patients or people with mental health issues, that is everybody. Of course, psychiatrists can tell things about that. We can help to screen psychiatric disease or mental health disorder. We can give advice for positive psychology, etc., etc. We can do that, but just as everybody else. We have no more legitimacy than other healthcare professionals. I would even say we have no more legitimacy than non-professional healthcare provider. This is not to say that we are useful only for patients with psychiatric disease. When you have a patient in your consultation who has no problem, when you say, you know, your kid has simply no problem, he is great, he is fine, you can change the life of your patient just with saying that. Because you have the legitimacy to say yes or no, there is a psychiatric disease, and if you say no, this is very strong. When you have patients with a psychiatric phenotype, you can give advice, you can propose medication. How do we have to call this patient? They have no psychiatric disease, so we could say they have a mental health disorder. Okay, you can say that. I prefer the notion of neurodiversity. I like that because my experience is that most patients with only psychiatric phenotype most often have no univoc deficit. Just take the example of attention deficit disorder. In the wording, it is deficit, attention deficit disorder. When it is only a psychiatric phenotype, and you have many patients like that, I am sure, of course, this raises many issues with school marks, etc., of course. And giving a stimulant can be helpful. On the opposite, I have many of these patients, because of their so-called disorder, are also creative, fun. And I have patients who told me, yes, the medication is fine, but my friends tell me, well, when you take your pill, you are less fun. You can give the pill nevertheless, because school marks are very important. Sure. But you are not in a medical position. You are just in a position to provide advices to your patient like everybody else. And of course, if you are in front of a psychiatric disease, you are in a completely different situation. You can give advice, and you have also to propose treatment which are efficient and effective. because this is how people consider you. This is not only something very theoretical, you know. It has a very practical implication. If you take patients with ADHD, whether they have only a psychiatric phenotype, that is a phenotype of ADHD, or whether they are a psychiatric disease, in the first situation, if you prescribe a stimulant, you will prescribe a lifestyle drug, which can be helpful, but it is a lifestyle drug. If it is a psychiatric disease, a patient with a psychiatric disease, you will prescribe a medication. This is the same pill. This is not the same treatment on a symbolic point of view, and our societies need to know among our prescription, which is the percentage of prescription for lifestyle drug and the percentage of prescription for medication. This is my last slide. We call in French, it is time to call a cat a cat. I think that instead of cat you have spade. It is time to call a spade a spade. First, psychiatric disease exists. I don't understand that. People say, no, don't use the word disease, it is disorder. No. There is Parkinson's disease, multiple sclerosis is a disease, schizophrenia is a disease. It is a psychiatric disease. It exists and it corresponds to something particular, which is a biological and syndromic construct which lead to a phenomenological rupture. And it means that mental health and psychiatry are two very different things. Psychiatrists have an official legitimacy to deal with psychiatry. We can be helpful for mental health just as everybody else. And this recognition will impact clinical practice, of course, but also psychiatric epidemiology. We need to have prevalence of psychiatric disease and mental health disorder, and this has been to be considered very differently. This will have an impact on evidence-based medicine. Why? Because I am sure that the effectiveness of SSRIs are not the same for psychiatric disease and for mental health disorder. I'm sure of that. And even for basic biological research, because the brain mechanism behind the disease or behind the mental health disorder are likely to be different. So this is a major point, but this is not the only one. Remember, we have also to listen to how patient and family experience their disease and treatment. And we have to remember that statistics and neuroscience are not the only science interesting for psychiatrists. If we can do that, we will perhaps get more credibility, and perhaps also child and adolescent psychiatry will become more a priority because of this credibility. Of course, I know this is open to discussion. And I hope that we will meet next year in Calgary for the AACAP Congress. Thank you for your attention.